All right, this morning on Your Side Mirror, we're returning to health. We're trying to see how you can stay healthy behind the wheels, and we're looking at it from the perspective of cancer, right? So this month is often referred to as the Colorectal Cancer Awareness Month, and that's why we are bringing in a specialist to help us dissect all of that. What is colorectal cancer? What are the challenges confronting those who live with it, and how can you get treatment as well? These are some of the questions we'll seek to answer as we reflect on colorectal cancer in Nigeria, challenges, opportunities, and innovations in care. Joining me in the studios this morning, Dr. Eben Adepitan Ajay is consultant clinical and radiation oncologist with the NSIA-LUTH Cancer Center, and he's very much here with us. Dr. Ajay, nice to have you in the building. Good morning.
Good morning. Thank you for having me.
It's been quite a while. We had you in the studios, by the way.
Yes, it is.
So how are you doing?
Very fine and happy to be back.
Wonderful.
Good.
All right. Okay, so let's just jump on it right away. I know that a lot of times we talk all things cancer on this frequency, especially when we bring in the NSIA people. So, and that's why this morning, Dr. Adepitan, let's do something and let's situate our conversation on the premise of March being a colorectal cancer awareness month. How did we arrive at that? I mean, what's the essence of that, really?
Okay, so what WHO has tried to do is to name every month after a cancer entity. Okay. And the whole idea is to increase sensitization, increase awareness about the disease. Interestingly, most of these diseases are preventable. Okay. So, and if they are preventable and they ride on human lifestyle most of the times, then it just makes sense that better awareness and increased awareness is going to help in driving the course of treatment and management of the disease.
All right. So we have it, if you say they weave it around every month, that means we have just barely 12 months in a year.
Yes.
Is that to say we'll be addressing only 12 kinds of cancer?
No. So the idea is that there are several cancers that are put together, okay, particularly in a particular month. But you would also understand that there are some cancers that seem to be prevalent in our society, some cancers that seem to be major, not lowering any other ones, but cancers like cervical cancer, breast cancers, colorectal cancers, these are topical.
They're very prevalent in Nigeria.
Very prevalent in our environment.
Are there other cancers that are not prevalent in Nigeria?
Well, yeah, there are other cancers that are rare. There are rare cancers.
Like which one?
Skin cancers are not as common as breast cancers.
In Nigeria?
In Nigeria, yeah. Okay. And there are other non-cutaneous cancers that are not as common as we have in Nigeria. Okay. Because cancers tend to follow geographic distribution and race.
Wow.
There are cancers that are more common to people who are of Asian descent, who are of Western descent than we have here.
These cancers, you think they discriminate too? That's what it means. All right, so leukemia, is it a cancer as well?
Yes, it's a cancer. It's a blood cell cancer.
Ooh.
Yeah.
All right, so we hear of cancers every day, Dr. Ajay, in Nigeria, and it is spreading, I wouldn't say like wildfire yet, but contextually, let's put it in context now. What kind of cancer is colorectal cancer?
Okay, so I would say comparing with what we had before, I think it's spreading like wildfire now.
You mean it?
Yes, it is.
So
it's spreading like wildfire because, the data shows us that there are more people coming down with this disease now as it was some 20, 30 years ago.
Yeah, but it's not like malaria.
Well, it's not like malaria, but the death, the mortality... The mortality is increasing. Close. Yes, it's increasing.
Wow.
Now, because of the impact of the disease that it has on the people. So, in answering your question, colorectal cancer is the most common cancer of the gastrointestinal tract, the tract that leads from your mouth to the anus. So the colon, that happens to be an integral part of that system, is where this cancer operates from. And the interesting thing about this cancer is that it rides on a tripod of a genetic arm, a tripod of an environmental arm, and a tripod of an inflammatory arm. So any of these three could be a causative factor? Any of these three are associated risk factors.
Wow.
For colorectal cancers.
That's dangerous.
Well, yes, that is why we're having the discussion this morning.
All right, so you've done like a background into it. Colorectal cancer, so it is not discriminated to male or female?
Okay, no, it affects both genders actually.
Both genders?
Yes, but it's just that it may be more common in men more than women, and this mirrors data and statistics.
Is that because we eat too much as men, or what?
No, I think it's just predilection, gender predilection to the disease.
Right. This is very, very wicked, this kind of cancer. Yeah. Let's talk about its prevalence. So how prevalent is colorectal cancer in Nigeria?
Okay, so colorectal cancer in incidence is the second most common cancer in men after prostate, and is the third most common in women after breast and cervical cancer. It's said that it's about 3.4 per 100,000 in Nigeria, which is high, compared to what our population is. Right. But I must also say that it's still relatively low compared to what we have in the West.
Wow. So in the West, it's much higher.
In the West, is much higher.
And if you place that in terms of impact on our public health, how would you describe it, Dr. Ajay?
It's the impact on our public health is grave, because it's a cancer of public concern, partly because one, is preventable, and two, its mortality is high. It's in the mortality, it's ranked the most, the fourth. Wow. In mortality, following prostate, following breast and cervix.
Are we saying now that if 10 people were brought to the hospital and they are already down with colorectal cancer, the likelihood of how many surviving? 3 surviving is rare?
No. So in amongst 10, maybe about 1, 2
will survive.
No, mortality.
Okay, mortality will die.
Yeah.
Okay. Wow. So it's really very, very crucial then.
Yes,
and
it is.
It's having much impact on our public health.
Yes, it is.
So what are the common risk factors?
So the common risk factors are factors that have to do with our environment in our diet. Now, because of the fact that we are gradually adopting the Western lifestyle of diet, we have more of processed foods. We take more of red meat. We take more of we relax more now than working. Our diets have less of fibers and less of fruits and vegetables. So it's beginning to impact or not. Sedentary lifestyle has also been fingered as a potential risk factor for this disease. Now, there is an inflammatory arm of the disease that is associated with bowel inflammatory disease. This is ulcerative colitis, and we have Crohn's disease. These diseases may be rare compared with the West, but of course, it's here amongst us. These are also strong risk factors. Social habits, alcohol consumption, very strongly linked with colorectal cancer, and cigarette smoking also linked with colorectal cancer. I must also mention that there is a genetic predisposition to colorectal cancer as it runs in family, but apparently this is just about 5 to 10% of all the cases that we have.
So most of the time, when you guys do your diagnosis, you check first for the genetics, right?
Yes, there is a genetic screening that can be done. Now, the genetic screening that can be done, aside from helping data, it also helps in the treatment of a patient, because those who have underlying predisposition genetically may not respond to the conventional medications that we give. So when we know that there is a genetic predisposition, like the Lynch syndrome, like other syndromes that is associated with it, their medications are more directly, they are more targeted, and we know that, from data and what we see here locally, there are better results.
All right. So causative factor, you mentioned 3 of them, right? Environment, genetics, and
inflammatory diseases.
Yeah. So at least those who are scared of because when we talk cervical cancer, for instance, we talk about multiple sexual partners and all of that. So people should not entertain that fear of colorectal cancer. But let's touch down a bit on how do we now begin to detect? What are the signs? What are the symptoms that will show that this is likely going to be colorectal cancer? Okay,
so in manifestation, I must say, and very emphatically, that there might be no symptoms at all.
No symptoms?
It could be asymptomatic. The person may just jolly well discover in a screening exercise. Maybe we'll come to screening later. We can talk about screening, but screening is important because there are just some patients who will not have any symptoms.
No signs will show.
No signs whatsoever. They just suddenly discover when they go for a screening, a colonoscopy screening, that there is a growth there, quiet, non-disturbing growth there. And by the time further tests are done, discover that it's a malignant process going on. So aside the category of those who will not have any symptoms, the other ones who have symptoms will be symptoms of bleeding per rectum. There is, when he goes to the toilet, there's this blood that accompanies urine. Now, there are several other things that could mirror that symptom, but it's important for us to exclude colorectal cancer. Now, there is an abnormal, unusual, and unplanned weight loss. When there is just this weight, the person is experiencing this weight loss, irregardless. This person is not fasting, he's not on any diet, but there is a weight loss. And fatigue, tiredness, these are all constitutional symptoms that could be associated with any other illness, but are more pronounced in colorectal cancer. And there is also abdominal distension, or abdominal pain, or abdominal swelling.
Okay. Because I just wanted to ask that question. I mean, isn't it possible by the time he eats one or two things, he begins to get some kind of reaction from his tummy? Yeah,
because at the point where there is a growth in the tube, essentially the colon is a tube. Is a tube that is packed into the abdominal space. So when there is a growth there, the free flow of fecal matter now becomes hampered. There is some kind of abdominal swelling, and there is some kind of associated abdominal pain. Now, there is a change in bowel habit that is also associated with colorectal cancers most times. There is an intermittency with constipation and diarrhea. He has constipation at some point, then he has diarrhea at some other point. So when that obstruction is active, there could be some degree of constipation. By the time that obstruction goes through, then the person now has diarrhea. So those are local symptoms. Then by the time the person is beginning to discover that there is an abdominal swelling, either on the right side or a generalized abdominal swelling, then we are having what looks like a more regional disease or metastatic disease. And it could affect the yellowness of the eye, extreme yellowness of the eye, or yellowness of the urine. That tells us that, this disease has gone from local to regional, and we're having a more a systematic picture of the disease.
So what about signs like hemorrhoids? I mean, people having hemorrhoids constantly?
Okay, so hemorrhoids, people should have their hemorrhoids checked. Because most times, a lot of people will tell you that it's usually I have hemorrhoids. It's just hemorrhoids that I have. And from hemorrhoids, sometimes there could be a transformation of hemorrhoids into frank malignancy. Because hemorrhoids also associated with bleeding per rectum, when you have blood in stool for hemorrhoids. And that will also, will move us into the issue of screening. Screening is key. Colorectal cancer is a preventable cancer.
I just wanted to ask that. So it's preventable?
Yes, it's preventable. If you know, we've highlighted the risk factors that are associated with it. If you're able to, live your life reasonably safely, then you subject yourself to screening. So there are different screening methods, but for the purpose of our audience that are listening, a colonoscopy is about the best screening method that there is. And it started by the age of 40 or age of 45, as the case may be.
So can one just walk into a health facility to say, I want to do a colonoscopy?
Okay, so there are people who have average risk and those who have higher risk. For the average risk person is you're 40 years old above, there's no family history of cancer, you don't have any family history of colorectal cancer, you don't have any family history of an adenoma or a growth in the intestine, you are of the average risk, right? There is no inflammatory bowel disorders, there's no cystic fibrosis. These are all disease entities. This person is of average risk. Now, that person can walk into a health facility and say, okay, I'm 40 years old and above, I know I need to check what's going on in my colon, and they recommend him. You go to your GP. GP recommends a colonoscopy for you. Now, the good thing about the colonoscopy, even though it might be a little bit of some discomfort,
because I hear it's a bit painful.
Not pain, maybe discomfort is the word, right? It's a scope that will be passed through the anus, and they will look through the whole tube of the intestine. If there are any suspicious growth or any protrusion coming in from that lumen, it can easily be pinched and can be tested. Now, other tests like fecal occult blood are of no diagnostic value. We have fecal occult blood. We have stool DNA. Now, if a stool DNA comes to be positive, you still need to do a colonoscopy.
You mean it?
Yeah, you still need to do a colonoscopy. If an fecal immunochemical test, FIT, is done and it's positive, you still need to do a colonoscopy. So why don't you just go ahead and do a colonoscopy and have it checked? And if you're given a clean bill of health, then your next check is another 10 years.
Okay, let's take this call. Hello there, good morning.
Good morning, Victor.
Grandma Lainka, how are you doing?
Good morning, sir.
Good morning.
And thank you. How was the weekend?
Very
and
good.
family?
Very good.
Good morning, doctor.
Good morning,
You're welcome.
Thank you, ma.
Thank you for this very beautiful information.
Yeah.
There was a question I was thinking about, but Victor has asked that if somebody is having frequent constipation, can it cause that cancer? Then secondly, sir, what is ALS? Is it a cancer? ALS.
ALS.
Grandma, yes. I wish you could break down the ALS, because
what test did you go for that they gave you?
I read it in one journal that the disease will break down the tissue. The muscle, the tissue, one will be weakened.
Oh, okay.
And most of the time they feel dizzy and all that, but they shrink. They shrink.
Okay.
Very painful. So I was wondering, is it cancer? Is it what? And then one woman in that journal said she lost a 16-year-old girl, daughter, to ALS.
Okay. All right.
Yes.
I'm sure the doctor would
Thank
say that. Thank you so much. I'm hoping that's not Alzheimer's disease or something.
No. It's a leukemia that you talked about.
Oh, leukemia.
So there is acute lymphoblastic leukemia. There's acute lymphocytic leukemia.
Wow.
So she's most likely, well, I don't know exactly what she read, but she's most likely talking about ALL or ALM.
Okay.
Blastic leukemia.
All right.
Or lymphocytic leukemia, as the case may be.
Okay.
But the question she asks about
frequent stooling.
Yeah, frequent stooling. Now, it could be a manifestation of anything. It could be a manifestation of anything. So we cannot pick up just one symptom and attribute it to colorectal cancer. But what I would suggest is that you go to your GP, have it adequately checked. Let them check you, let them examine you. But changing bowel habits, alternating between constipation and diarrhea could be colorectal cancer.
All right. And you said this is not limited to men alone?
It's not limited to men alone.
So women also suffer?
Yes, it affects both men and women.
All right. 08099120777. We can also have your input on the program this morning. The doctor is here to respond to your concerns. Traffic-wise, those of you on Ikorodu Road, slow and steady, that's the name of the game, especially from the inner part of Ikorodu. The travel advice for you is for you to navigate through Garage, connect Haruno, and link up with our Greek to proceed on your journey from there, rather than going through a Bute Ikpakodo corridor. Yes, so that's the report from the traffic manager there. Mile 12, heading towards Koshofe, and K2, slow and steady. That's still the name of the game. And same for you, navigating towards that and linking up with the interchange and Ojota proper. Orile Gomu, vehicular movement from Ijora Lokpa inwards Eko Bridge, looking pretty good to go. Eko Bridge connecting Ijora Causeway as well as Ijora 7 Up, also looking good. Ijora 7 Up inwards Moshood Abiola Way, sending Igomu Bridge is also looking pretty good to go as we speak right now. Igomu Bridge inwards Breweries also looking good, and then Breweries ascending Igomu Bridge down to Donyi. Talking about the bus stop there, it's also looking good. Don't you link it up with Orili bus stop, connecting Alafia, Koka, and the Suru, Alaba, Signal Barracks, all looking pretty good. Return journey, not bad at all. 08099 120777 09153877127. Doctor, before we can take some calls, let's talk about the facilities for treatment. Do we have them in Nigeria?
Yes, we have facilities for treatment. At the NSIA-LUTH Center, we have 11 clinical oncologists who are present on site, on ground at the facility that treats colorectal cancer. I only happen to be the lead of that team, that treats colorectal cancer as an interest. But there are other specialists who are there too to treat colorectal cancer. And I must say that there is a clinical trial now going on with in affiliation with MSKCC, in trying out some medications for people who have Lynch syndrome, those who have MSI high, who have a defective microsatellite instability. So, I mean, there are initiatives that are going on, and there are processes that are further to be put in place, to help the treatment of this disease. I must say that surgery usually is the mainstay of treatment when it's at an early stage. So we need to have our medical checks done. When we have a medical checks done, I've talked about the screening colonoscopy, and they find something out, it can easily be taken out at that stage. However, if it's missed at that stage, then we have adjuvant treatments that can come either by the way of chemotherapy, or if the disease is situated in the rectum, they can have radiotherapy done, which equipments are available at the NSIA-LUTH Cancer Center.
Can it be cured?
Now, so in answering the question of curing, it depends on so many factors, but germane of the factors is the stage of presentation. If it comes at a stage 1, a stage 2, yes, with adequate treatment, it can be cured, right? And patients will be on a long-term follow-up. Right, but when it comes at a late stage with metastasis to other vital organs, we can only manage the patient palliatively. We cannot cure.
Okay, so one has to look at all of that. But in terms of those that are presenting, I mean, in your clinic, are we seeing more people coming down with colorectal cancer? Okay,
so in my clinic, colorectal cancer is not the most common cancer that presents in my clinic. Breast cancer is the most common for female, and prostate cancer most common for male. However, in the first 5, we'll talk about breast cancer, colon cancer, cervical cancer, and colorectal cancer comes number 4.
Wow. What about prostate cancer?
Prostate cancer comes number 1 for men.
Okay, for men.
Yeah.
All right. 08099120777. 09153877127 09153877127. Those are the numbers if you want to ask the doctor any question. Messages here are coming in. This one says, good morning. Are women more in danger of colorectal cancer than men? Sukomi is asking that question. Sukomi, thank you so much.
No, women are not more in danger than men. Although I had emphasized earlier that it affects both genders, just that men are more affected than women, slightly more affected than women.
All right, so it's like a 60-40 kind of ratio.
Yes.
All right. This one says, good morning, Victor. Doctor, is there enough awareness about colorectal cancer, or is it often detected too late? Anike is sending this one in. Anike, thank you so much.
Yeah, this is one of the awareness avenues in which we're shedding light on it. And as we continue to make more noise and talk about it, we hope that there'll be more awareness amongst the general public.
All right, let's take this call. Hello there, good morning.
Hello, good morning, sir.
Good morning. Please turn down the volume of that radio.
Oh, thank you very much.
Hello?
I'm there, sir. Thank you. Good morning.
Okay, Oluwaloko.
Thank you very much. Oluwaloko is my name.
Good.
Please, I want to pardon me for the noise from the background.
Yeah.
I wasn't near the radio. Please, I want to ask our doctor, because I've been listening to most of this health discussion, because Grandpa is already catching up on me. Okay. And I thank God for traffic radio. What I eat, I just really got most of this information from. I want to ask her, most of this cancer you're talking about, especially this one you're discussing this morning, is it prevalent more among the older people, especially men, than, because these days I've been to the hospital many times, checked, they didn't see anything. But when I get home, I just discovered that it's my muscle that is getting weaker and weaker. But I want to ask, is this skin prevalent among men alone than in women? Thank you very much.
All right.
Okay, so it affects most commonly from the 4th or 5th decade of life.
Okay, from 40s upwards.
From 40s upward. That's why screening is advised to start from age of 40. So most of our patients come at the age of 50, 60, thereabout, and of course in the elderly. But I must say that there are patients who present at earlier ages. Patients who present at between age 20 to 30. We've seen cases of people who present between that age bracket, and usually their disease outlook is usually more aggressive and more rapid than those who present in the 5th or 6th decade of life. So it affects all age brackets, but it's just that it's more common in the 5th or 6th decade of life. Well, it's good that you're going for medical checks and you're having yourself examined. I think you should also take a closer look of your activities and make sure that your stress level is within the optimal limit.
Okay. All right, then. Lagos Traffic Radio, that is 6.1 FM, 09153877127. Hello there. Okay, well, let's start one. This one says, Happy New Week. Please, how much does colorectal cancer screening cost in Nigeria? Oh, that's a very good question, but you didn't put your name. Thank you so much for sending in that question. So, is it very, very cost effective?
Yes, it's cost effective. It's cost effective. I may not be able to put a price tag on it, all right, but I'm sure it's not off the roof. But
Okay.
it's cost effective.
All right.
And I'm sure that most HMO plans, most health insurance plans,
They cover the screening.
Cover colorectal cancer screening.
All right. So, thank you for sending that question in. This one says, Good morning. I am B from Ogba. Okay, our regular B says, from what age is regular screening advised?
From age 40.
Okay, age 40 and above.
Yeah.
All right. Have you seen any patient that has come down with like age 25, 28?
Yes.
You've seen that too?
I am managing currently an age 23.
Wow.
I'm managing an age 21.
23, 20. What would have been responsible?
Yeah. That's why I said that there might be a genetic predisposition.
Ooh. Wow.
And their disease is usually very aggressive.
Very aggressive for the younger ones.
Yes, for the younger ones.
Oh, quite unfortunate. All right, then let me see. Updates coming in at this time. This flash update says there is the report of a Dangote truck loaded with sugar broken down while ascending a Gomu bridge inwards Orile. It's having a gearbox and a propeller problem. All right, the gearbox, I understand, fell off. Oh, efforts on to repair it before the truck can be towed. This is while ascending a Gomu bridge. Take note of that. This is from the control room. Thank you so much for sending that one in. 08099120777 and 09153877127. These are the numbers that you can connect with us. And of course, if you also want to have your say on the program as relates to any form of cancer, feel free to connect with us. Dr. Adepitan Aji is very much here with us. Doctor, stigma. Do we have stigma attached to this kind of cancer?
Okay, so the only stigma that is attached to this kind of cancer is when there is a diversion. Now, with an obstruction in the distal part of either the colon or the rectum, as such that the person can no longer pass stool through the anus.
Okay.
What the surgeons do is to bring out the intestine by the side and connect it to a bag, which is called a colostomy bag. Now, depending on the technicalities and the skill of the surgeon that fashions that bag, it may not be properly managed, so that you could have fecal material sometimes seep through it.
Oh.
But if you have a professional that fashions a colostomy and it's well positioned, I mean, there are people who carry colostomy bags and you will never know that they carry a colostomy bag because it's well positioned, well taken care of, is well emptied, and they do very well on colostomy bag.
Wow.
So that is about the only stigma that may be associated with it. But if you look at it by and large, it's better for the patient. The outcome is better. Patient can live far longer, and the quality of life of the patient is better ultimately with that kind of an arrangement.
Right. But anyone who has cancer, can he still perform this kind of cancer, can he still perform all functions that he's supposed to do?
Yes, he can. He can. If the person presents early and is well taken care of, he will do very well. We have patients who we've treated and they've gotten back to work after their treatment period.
Including performing well in the other room?
Yes, in the other room. So very well. Person can perform very well in the other room.
Okay. This one says, good morning, Traffic Radio. Are there initiatives aimed at what? Okay, aimed at reducing the financial burden of treatment of patients?
Okay, so I just mentioned in person that health insurance covers some screening. It covers screening methods. When you have yearly screening of people who are in health insurance cover, that is a particular screening method, cost reducing method, and I think it's cheaper when you see the specialist than having to see those who are not specialized in that kind of treatment, because for most patients, which mirrors a lot of the narratives, that they would have spent monies having seen other doctors who do not particularly offer them good quality service,
right?
And eventually when they now get to the tertiary hospital or the tertiary center and they have to spend twice or three times the amount that they had spent earlier.
Let's talk about treatment now and options. Do we have options? Are there varieties of treatment, or is just a one-way kind of treatment?
No. So we had mentioned varieties of treatment depending on the presentation, depending on the stage that the patient presents. So
let's take this call. Hello there. Good morning.
Hello. Good morning. It's Grandma Alanka again.
Okay, you're back, Grandma Alanka.
Thank you. Please, doctor, is it most of the teaching hospitals that we have treatments for this cancer? Then what is bone cancer called?
Brain.
And is it frequent?
Okay, all right.
Bone cancer.
All right.
Is it bone or brain?
Bone.
Bone.
Okay.
All right then. Thank you so much, Grandma Lainka. Thank you. Bone cancer.
So
what's it called?
It's usually called a sarcoma.
Sarcoma.
Yeah, it's an osteosarcoma or chondrosarcoma. These are because the bone is a connective tissue. It's a mesenchymal tissue. So that's what we call bone cancer, an osteosarcoma.
Okay.
Yeah.
I know we've touched on sarcoma before last year, and that was sometime around August.
Yes.
We did something on sarcoma cancers. All right, then. So, and I think the first question was. I'm trying to remember Grandma Lainka's first question now. Okay. All right. But 09153.
So we're talking about the options, options for treatment.
Yes.
So I was mentioning that at earlier stages, when you come at an early stage, surgery is the best option for treatment. And after surgery being done, patient is amenable. Patient can be cured after surgical intervention. However, at earlier stages, then we now have adjuvant treatments that can be instituted, which is chemotherapy or targeted therapy or immunotherapy, as the case may be. Now, when you now come to the rectum, surgery also is mainstay. There are new models of surgery, laparoscopic surgery that are coming for now, but just to say that surgery is mainstay of treatment, and there can be radiotherapy too, and there's chemotherapy too, as forms of treatment, depending also on the stage of the patient.
All right, so even as we gradually wind to the end of the program this morning, Dr. Ajay, in terms of recommendation, what would you expect, and what are you putting out for our listeners this morning? What should they do to avoid colorectal cancer? So
when you celebrate your birthday, which is what I usually say, be the first beneficiary of your birthday celebration. A week to your birthday or a day to your birthday, go to a hospital and have your numbers checked. Do a full investigation. Do your blood work, do your tumor markers, do your imaging investigation, do your scope investigations. And when you have a clean bill of health, that is your birthday gift to yourself. So let's be more health aware. It's good we pray, it's good we spiritualize it, but God also expects us to take responsibility for our health. Thank you. All
right, then. Great words of advice. And for those of you, for those who come down with this, you said NSIA-LUTH Center. Where are you guys located?
Oh, so NSIA-LUTH Cancer Center is in the University of Lagos Teaching Hospital, which is in Idiaraba, Surulere. And we are there to attend to your cancer needs, either at a consultation basis or at treatment basis, and even at screening basis.
Yeah. All right, then. We'll leave it at that for now. Nice having you in the building.
Thank you very much for having me.
Okay, this morning we've done an excursion into a very special kind of cancer. And like you heard, it's also prevalently high in Nigeria, behind breast and cervical for women and behind prostate for men. That's where you'll find colorectal cancer. So you need to take charge of that and ensure that you do all the screenings as the doctor has said this morning. All right, then, I must say a very big thank you to our guests who have made it very, very possible navigating through this. And I'll talk a little bit about Dr. Eben Adepitan, who is consultant clinical and radiation oncologist with the NSIA-LUTH Cancer Center. And of course, he's been able to take us to the classroom. Maximum thanks to our producer this morning, Mike James. He's produced. And I say a big thank you to Moloku Onora, who is a cancer advocate, and he's working tirelessly behind the scene to ensure that you have all this information loaded into your system from time to time. Kausara Bakri in the building as well. Oluwatoni Olushoga also here. And from our social media team, I do appreciate Okwayemi Shodunke and Oluremi Aluko. Maximum shout out going out to our executive producer, Tayo Akonle. My name is Victor Oteri. I'm out. Stay very much within. Bye.
I will never forget your healing hands, my love. Although my heart has stopped, it's what I've given up. I will never forget.